Morning, guys. Dr. Gillard here. Let's do our endocrinology lecture. So this would be for Monday, week 3. And yeah, so we're starting on hyperaldosteronism is where we're starting off, or where we left off. So let's talk about hyperaldosteronism. So it's too much aldosterone. Hyper means too much. So it's a problem with too high levels of aldosterone in the blood. It's also called aldosteronism. Be careful with that, aka. I like that one if I was writing board questions, aldosteronism. Because if you say hyperaldosteronism, well, you know there's too much aldosterone in the blood. So I like aldosteronism. And if you have too much aldosterone, we've already talked about aldosterone, I believe. And aldosterone causes the reabsorption of salt, and water follows. So you get increased blood volume, which causes hypertension. And that condition is what brings people into the doc, or they come in for their annual physical, and lo and behold, they have hypertension. And that needs to be worked up. And hyperaldosteronism has to be ruled out as a cause of de novo, which means, what's de novo mean? De novo means new. So new hypertension. So too much aldosterone in the blood causes the following. So let's list all the things that aldosterone does. So we said it increases salt in water. So that causes hypernatremia and hypertension, right? As I just explained. And let me, just real quick, let me write down a slide here. Make sure I don't go too long or go too crazy with these slides. All right. So it can also decrease. So remember the classic effects of aldosterone. Absorption of salt and water, hydrogen ion and potassium ion get the boot, kicked out into the filtrate. So it causes decreased blood potassium levels, which may, not always, cause hypokalemia. In fact, in reality, you have to have moderate to severe levels of aldosterone in your blood to actually do this. Most people don't have this, as we'll see. But if you do, if you have, if you are low in extracellular potassium, well, it's going to make the cells hyperpolarize the cell membranes, and it makes muscles weak and twitchy, and fasciculations occur and things like that. Well, severe muscle weakness is kind of directly proportional with the amount of potassium lost. What else does it do? It causes a decrease. Well, if hydrogen ion gets kicked out, then it increases the pH of the blood. It makes the blood less acidic and more basic, and that's called metabolic alkalosis. What about renin? So if you have hypertension, that's going to shut off the R2A system, right? Juxtaglomerular apparatus is not going to be stimulated, so you will have low levels of renin. And in fact, in modern times, the ratio of aldosterone to renin, that ratio is very important in making the diagnosis of aldosteronism. And then I had to add this wasn't in Jameson, but I mean, who cares about all this stuff? Who cares about it is aldosterone can damage. We talked about how it can damage the heart, and it can damage the cardiovascular system, especially the heart, by turning on genes which make kind of scar tissue, and it makes the heart scarred up, and the heart doesn't beat very good. So it's very important to prevent heart damage that you catch this. Aldosteronism, again, most common cause of secondary. We will talk about primary versus secondary hypertension. Primary hypertension is 95% of people are diagnosed. Maybe some of those people weren't worked up enough and just put on medication by docs who maybe weren't the sharpest tool in the shed. If you have brand new hypertension starts, that needs to be worked up to make sure. You can't figure out a cause for it. But if you do figure out a cause for it, by far the number one cause of cause-identified hypertension is aldosteronism. In fact, in patients who you give a first round of treatment to, let's say one medication for lowering blood pressure, and it doesn't lower the blood pressure, 18% of those people will have hyperaldosteronism. So that's not good. And in fact, research shows that just that the hundreds of thousands or millions of people with hypertension running around, 8% of them actually have hyperaldosteronism, and they don't know it. They haven't been worked up properly, and they're damaging their hearts. So not good. There are two flavors of aldosteronism or hyperaldosteronism. We have primary and secondary. Primary is called Conn syndrome. On boards, you're probably going to see Conn syndrome because that's even better than aldosteronism. If you say Conn syndrome, you're going to have no clue. You better know Conn syndrome is an AKA for hyperaldosteronism and aldosteronism, but it's primary hyperaldosteronism. There's a difference. We'll look at secondary in a bit. We'll look mainly at primary because that's by far the most common. So that means that the adrenal gland is the problem. Conn syndrome, the adrenal gland, and nothing else is the problem. Because we can have an overproduction of aldosterone if you get the R2A system on, right? Angiotensin II is a second strongest stimulator of the release of aldosterone. So you can get it from that as well. But that ain't it. That's secondary. Primary means that something's screwed up with the adrenal gland or something, ectopic adrenal tissue is located somewhere and secreting aldosterone. So again, it's very important to catch this early and treat before it wrecks your heart. What about the exam findings, or what will you find on clinical eval in someone with Conn syndrome? They'll typically have really high blood pressure, moderate to severe hypertension, both systolic and diastolic hypertension. They'll have raised levels of aldosterone, and they'll have low levels of renin. Therefore, they'll have an increase in the aldosterone to renin ratio. So let's say if you have a flat, a negative, like a 0 ratio, they're equal. Let's just use a cartoon. We'll say 5 and 5 is an equal ratio. If you have 20 units of aldosterone and 1 unit of renin, that's a really high aldosterone to renin ratio. Got it? So what if there's 1 unit of aldosterone to 10 units of renin? Is that a high? No, renin's high, so that's a low aldosterone to renin ratio. Some people have trouble with these ratios, and examiners like me and like boards, they love to throw these questions, these ratio questions. So make sure you understand that. So that means the serum aldosterone levels are increased, but because of the hypertension, the R2A system or the RAS system is shut off. Whichever, prefer R2A. I've always learned it like that, but RAS is another popular way to say that. Yeah, so example, 50-to-1 ratio of aldosterone to renin. We'll see some exact numbers in a bit. What else we find on exam? Well, you might find if the levels of aldosterone are high enough, if there's a high enough aldosterone to renin ratio, you might actually see some decrease in serum potassium levels, which the body does not tolerate very well. So, in other words, you'll have hypokalemia. And on my exams, watch out between hypo and hyper. You have to read those carefully. Don't let your eyes play tricks on you. Make sure it really says hypo, because I like to, that's one kind of question. I like to put hyperkalemia instead of hypokalemia. So watch out for that. Hydrogen ion gets the boot. We said we got metabolic alkalosis. Don't need to say anything more about that. What are the causes of Conn syndrome? The number one cause is an adenoma in one or even both, but usually in at least one of the adrenal glands. And these adenomas, that's a glandular tumor, and it's usually made up of glomerulosa cells, and those glomerulosa cells are what secrete aldosterone. So you have a gland-secreting tumor found in the adrenal gland, and it's cranking out aldosterone, and it has no receptors. You can't shut it off. So it just spits it out like crazy. And maybe it's one little pea-sized tumor. Maybe it looks like this. So it often tends to be bilateral idiopathic adrenal gland hyperplasia. It's really not the greatest word for it, but that's what they call it. But idiopathic, we know it's from an adenoma, but we don't know why does the adenoma grow there. We don't know why that is. But here's a patient who, as you do histology of this ugly looking, these are not cancerous tumors, but they're giant tumors filled with adenomas that secrete aldosterone. This patient was so bad they had to remove both his adrenal glands. You can't live without your adrenal glands, right? Or can you? You can't live without them unless you take replacement hormones, and that's what they have to do. And that is a really tough thing to have, because stress and things like that can make your hormones levels flip all over, or the need for hormones change. So it's very tough to have to take pills for that stuff. So 60% of the time, this is the problem. They have these adrenal gland adenomas, and they secrete aldosterone. They're not cancerous. They can be cancerous in some cases, as we'll see, but not today. So number one cause of primary or Conn syndrome is the bilateral idiopathic adrenal gland hyperplasia. All right, how about some other causes of Conn syndrome? Well, we've talked about ectopia before. With ectopia, let's see, in the esophagus, right? You can have an ectopia of stomach mucosa living in the esophagus secreting acid. You can have, we'll see lots of examples of that, and this is one. You can have aldosterone synthase ectopia, where aldosterone synthase is in other places. The most common place is the next door neighbor, the zona fasciculata, which is not supposed to have the enzyme aldosterone synthase makes. Remember, that's that last step. It makes aldosterone. And if you have that in the next door neighbor, you can crank aldosterone out of the zona fasciculata as well as the zona glomerulosa. So that ain't good. What about glucocorticoids? Well, remember, glucocorticoids can also bind to MR receptors, right? So you could have a glucocorticoid-mediated hyperaldosteronism. Of course, you would also have hypercortisolism or Cushing's disease on top of that, which is usually the biggest problem. But nevertheless, that can also raise levels. Because cortisol, if you have Cushing's disease and it's cranking out cortisol, they can bind with glomerulosa cells and start to stimulate the release of aldosterone as well. Okay. Conditions with overproduction of cortisol, you get also ACTH would be, well, it doesn't have to. It depends what the problem is. Okay, so 3 types of gene-related. Some other causes of Conn syndrome. There are several gene-related mutations where the cells of the zona glomerulosa secrete too much aldosterone. There's 3 types specifically. They're probably the most common. There's type 1, 2, and 3 familial hyperaldosteronism, where the adrenal gland just secretes too much aldosterone. And we won't get into the mechanism. They're not 100% sure of the mechanism, but it just cranks out too much aldosterone. Then the one that no one wants to know is, how do you tell the difference between these and cancer? I mean, cancer's probably not going to look like that. You're probably going to have one cancerous tumor, unless it's metastatic disease. But nevertheless, a certain percentage do get a cancerous tumor, which can oversecrete aldosterone or any hormone for that matter. So that's another cause. All right, what's one way to diagnose Conn syndrome or any hyperaldosteronism? The aldosterone to renin. This will actually differentiate between primary and secondary hyperadrenalism as well. So this is an important test. It's high up in the 90s sensitivity and specificity for making the diagnosis of hyperaldosteronism. And in the past, MDs and maybe some kind of, again, not sharpest tool in the shed MDs, maybe they don't order this test when somebody becomes hypertensive. And that's a big mistake. In the past, they used to wait until the patient had hypokalemia. And if they had hypokalemia, then they ordered and started thinking about, oh, gee, something's got an adrenal tumor or something. But that's a huge mistake. Prevalence of hyperaldosteronism is under 1% based on this methodology. So it greatly underestimates aldosteronism. But now we know that most patients with primary don't even have hypokalemia yet. So that's more of a later thing. By the time they have heart damage, by the time they figure it out. So if new hypertension, you need to order an aldosterone to renin activity test to see what's going on. And I'll show you some other testing for this as well. But it measures, again, the plasma concentrations of aldosterone versus the plasma concentrations of renin. You just order it. It's so simple. And it's known as the aldosterone to renin ratio test. There's a big aldosterone to renin activity test is the official word, but I think that's good enough. And instead of under 1% as a prevalence, now it's up to 8% of all hypertension patients. So that's a huge difference, right? Can you imagine how many hearts were ruined because of this? But hopefully now they're all testing for this when you get new hypertension. So many damaged hearts out there from failure to do this test. Why didn't they do the test? Because they didn't have hypokalemia yet. And that is not, if they have hypertension, you need to do that test. Let's talk about hypokalemia a little bit. So those with moderate to high levels of aldosterone in their serum, in their blood, will have hypokalemia. It's not as common, but when it comes, it's a problem. So too much aldosterone causes to kick out too much potassium. I've said that like a million times. So classic clinical signs, since it makes it kicks, if you remember, I'm not going to go crazy into physiology, but remember, if you decrease the levels of potassium in the interstitium or the extracellular fluid, it makes the cell membrane hyperpolar. It makes it very irritable, right? So it makes it a membrane like that's hyperpolarized. It's cranky and it's twitchy, and it doesn't work if it's around a muscle, which it will be. The muscle doesn't work that good. So you get weak muscles. You might get some twitching, fasciculations, which are normal, stressed out people anyway. So just because you have fasciculations doesn't mean you have hypokalemia. And then they can start cramping up, and the muscles don't work right. Boards tend to like tetany. Hypokalemia equals tetany. Rarely happens. Have to be really high levels of aldosterone. But it does occasionally happen, and for whatever reason, boards, to my understanding, seem to like that. I remember my cardiovascular pulmonary endo professor drilling that into our brains, and I think that's still true today. It also makes the heart cells twitchy, and you can get palpitations of the heart and even some arrhythmias. And then here's the weird one. The students always have trouble with this. It causes polyuria. So let's think about that. Now, those of you who know quite a bit about this are scratching your heads right now. Why are you scratching your heads on polyuria? Well, what is polyuria? That means there's too much urine. You're urinating too much. So, but wait a minute. If you have too much aldosterone, well, how does aldosterone affect water in the filtrate? Well, aldosterone causes a reabsorption of sodium, and water follows. So how can you be peeing too much if you're soaking up water? And then polydipsia, what's that? Make sure you know these words. I assume you know these words. If you don't, put them on your vocabulary list. That's you're thirsty all the time. Why you're thirsty? Because you're peeing all the time. You're peeing out the water. But yeah, it's a very complicated answer. But the hypokalemia, probably the easiest answer is it damages the proximal convoluted tubule. And remember that tons of water and salt are dumped out of the Bowman's or into Bowman's capsule, and that 75% of salt and water are returned into your bloodstream. into the interstitium, which soaks into the capillaries, gets into your bloodstream via the proximal convoluted tubule. Remember, these are the potato pickers. It's important for picking sodium, and then water follows. But people with hypokalemia, there's damage to the potato pickers, and they can't return the sodium and therefore the water, so you pee it out. So that's probably the easiest answer. There's also a problem with aquaporin's 2 channels that let too much water in. And yeah, the kidneys are damaged, and they still don't understand the mechanism completely, but I think that's the easiest to grasp. Proximal convoluted tubules are damaged from the hypokalemia, and they're not working right, and they can't pick. The apple pickers are broken. Even though if the apple pickers are broken, macula densa is not going to be turned on, right? It's looking for low sodium. It's going to have high sodium. Okay. Let's see, hypertension and Conn's disease. Once again, hypertension is moderate, and let's be more specific. It's typically, on average from several studies, about 184 over 112. That's pretty darn high hypertension. So it's high. And yep, the higher the hypertension is, the more likely they are to have primary aldosteronism. And the other secret for making the diagnosis is it's resistant to the usual first attempt at treating it. It might be resistant to all attempts to treat it with all medications. Typically, the doc will give you just one pill, and then they start adding pills to combat it. But if it's resistant to treatment, that raises an eyebrow that, I wonder if aldosterone is being cranked out by something. Again, it's the most common form of secondary hypertension. About 20% of patients with treatment-resistant hypertension, the problem is the adrenal gland is cranking out too much aldosterone. What about primary hyperaldosteronism versus the R2A system? Well, again, we've said this. The R2A system is not activated. Why? Because aldosterone causes the reabsorption of salt and water, and you have hypertension, even though you're urinating a lot, which is just a weird kind of a thing. But yeah, so that shuts off the juxtaglomerular apparatus. So you get very low levels of renin secretion if the R2A system. Therefore, the aldosterone to renin ratio is very high. What if I was really evil and said the renin to aldosterone, or the renin to aldosterone ratio? Well, then it would be low, right? But I won't do that. I'll keep it the way it's written, aldosterone to renin ratio. But if I did, you should be able to flip those around. So here's the real numbers. Typically, you have about 500 milligrams per deciliter of aldosterone to about 2 millimeters per deciliter of renin. And so if you do the math, 500 divided by 2, so your your aldosterone to renin ratio is 250. Okay, so that's quite high, right? That's high. How about diagnosis and treatment? There's some other things. The first thing that you will do is get a CT scan and look for tumors on the adrenal gland. If you see a tumor, you can take a biopsy of it to make sure it's not cancerous. There's a bunch of blood work we've talked about. In addition to the aldosterone-renin ratio, you can also order a adrenal vein blood test where they stick a catheter in your common femoral vein and go up into the renal veins and then take a sample of the right and then do the same thing to the left and see how much aldosterone is being cranked out of those. Maybe the right kidney's cranking out super high levels of aldosterone, the left kidney isn't. That's a sign that the right kidney, something's messed up with it. If it's bilateral, they can tell that as well. If there's high levels of aldosterone coming out of both of them, then you get a bilateral problem. The patients are also put on a sodium diet because they do struggle with hypertension from the water reabsorption, so low sodium diet. They have to. So what's the treatment? Well, you can either surgically remove the problem, take out the adrenal glands, and go on pills. If it's not too bad, you can go on mineralocorticoid. Who's the mineralocorticoid? What's that almost an AK for? Mineralocorticoid. That's aldosterone, is the king of the mineralocorticoids. So you're on mineralocorticoid receptor antagonists. Remember, antagonists are blockers. Antagonists. Agonists are stimulators. Antagonists are blockers. So they bind to the MR receptors. And so all that aldosterone doesn't have as many targets to bind to. So the doses are kind of hit or miss. You got to figure out how much of that to have, because you can't block all the aldosterone receptors, right? And then you'll be in trouble. You have to leave them going. Aldactone is the number one of these, number one prescribed. And if you have to remove it, then you have to take it out. Maybe it's cancerous, or maybe it's your aldosterone levels are so high in your blood pressure you can't control it. You have to take out those adrenal glands, and that's possible. And it's actually preferred when super high uncontrolled hypertension, because the hypertension will kill you. And the trouble is you have to take replacement hormones, take out your adrenal glands. There goes your aldosterone, and there goes your cortisol, not to mention your sex hormone, or your adrenal cortical sex hormones, DHEA is gone. And that, you can live without that, but you can't live without cortisol, so that has to be replaced. And so does the aldosterone, and aldosterone might not be too hard to do, but the cortisol, replacing cortisol is always the tricky one, because your body needs cortisol in very specific amounts for specific situations, and you have to learn how to adjust the amount of cortisol replacement that you take. We'll actually talk about that. Secondary hyperaldosteronism. So let's talk about that. Excessive aldosterone secretion occurs secondary to the R2A system. So primary hyperaldosteronism is a problem with the adrenal gland. Something is spitting out aldosterone. Secondary aldosteronism, which is not called Conn syndrome, this problem is with the R2A system. Something is chronically causing the R2A system to fire. So angiotensin 2 is around, aldosterone is around, and we sure know those damage the heart, right? So this one's even more damaging to the heart than the other one, because now we got angiotensin 2 going. Primary aldosterone, hyperaldosteronism, angiotensin 2 is not wreaking havoc. It's just aldosterone. Okay. One of the most common causes of secondary hyperaldosteronism is people with a failing heart, or anything that decreases blood pressure, for that matter, or decreases cardiac output. Heart failure is really common for that. So let's look at the causes. So heart failure. How in the world? What do you mean heart failure? That's crazy, right? Because heart failure means you have hypotension and you have hypertension in aldosteronism. So what's the deal with that? And we talked about the beaver dam. I don't need to do that again. But if the heart fails, it doesn't inject blood. Maybe the heart is okay, but the aortic valve is closed too tightly, and you're not ejecting enough blood. So you're getting low blood pressure. Maybe you have regurgitation disease, and you're still not getting a good ejection fraction because some of it backwashes. But anything that causes hypotension, well, who's going to sense the hypotension? The kidneys are, and they're going to spit out renin. The R2A system's going to be turned on, and it overdoes it. And you have too much angiotensin 2 around, and to the point where you have too much aldosterone around, and that's going to cause hypertension. Sodium and water are going to be reabsorbed. And you're going to have the natriuretic system on to trying to fight this. That's not going to let it get like crazy, super, super high. But it doesn't do a good job of controlling it. So you always have chronic hypertension. You can't balance. I don't know why you can't balance. I would like, if somebody knows, please put in the comments below. But you don't. You get a hypertension. So other things. What if there's something wrong with the kidney? Well, if the kidney is broken and you can't reabsorb sodium. Maybe there's some disease and it's affected the proximal convoluted tubules and you can't reabsorb the sodium. Well, there goes your water. And you have hypotension, and that again turns on the R2A system. And then what if all that stuff, what if your heart's okay and your kidneys are okay, but you have a tumor, or let's say, how about an abdominal aortic aneurysm that's big and it's pushing on the renal artery, and it's acting like a beaver dam, so you're getting downstream ischemia. That's going to tell the kidney that, kidney doesn't know that only the kidney is having low blood pressure. Kidney doesn't know that between the whole body is having low blood pressure. All it cares about is saving the kidney. And so that'll crank out aldosterone, or that'll crank out renin. It'll turn on the R2A system, and you know the rest of the story there. So renal artery stenosis from anything. Maybe it's atherosclerosis really bad. So anything like that. Now, what about, I should have put like 1,000,000 stars here, because I do like to ask this question. What about the aldosterone to renin ratio in people with secondary aldosteronism? Well, it was super high in primary, but in secondary, it's going to be super low. Yeah, right? Super low, because aldosterone's going to be cranked out there, but this time the R2A system's turned on, and renin's going to be much, much higher. So typically you would see something like, aldosterone is still higher. You see like 500 milligrams per deciliter of aldosterone, and you'll measure 300 milligrams per deciliter of renin. So if you do the math, that comes out to 1.7. Remember, before we had 250 is the ATR ratio. So that's a much lower ratio. So I almost guarantee you there's going to be a test question, at least one on that. So make sure you understand that. Let's see, how are we doing on slides? Got a little more time. Let's start ADH, right? Antidiuretic hormone. Let me take a drink of water here. You can peruse that slide. So a bunch of AKAs. Some of these you don't know. ADH, vasopressin is a really common one. Arginine vasopressin is another one. Argipressin, which is kind of a takeoff of arginine vasopressin, is another one. So you should know all these, especially vasopressin and ADH, and arginine vasopressin. That one tends to be used when really high levels of ADH are being released. But this is the key hormone for controlling water homeostasis via osmoregulation. So it squirts water into the blood when sodium concentration gets too high, and it turns off when sodium concentration gets too low. Right? We want the ratio between sodium molecules, water molecules has to be just right in the blood. So how does it work? It signals the kidneys, go back to our principal cells again in a little while, signals the kidneys to conserve free water. But here's the rub, because water and sodium and water always travel together, right? Not right. Not when ADH is involved. It causes the conservation of free water. Sodium cannot follow, which is a little bit strange. So in high enough concentrations, here's the other strange things about ADH. It actually is a powerful vasoconstrictor, and it affects the arterioles and venules. If you're bleeding, high levels of ADH will be released, and it can help vasoconstrict. Along with sympathetic tiger, it can help vasoconstrict those blood vessels to save blood for the more important organs, kind of boost the pressure back up. Who makes it? I think you've had this before, but this is important to know. Easy board questions. It's made mainly by magnocellular neurons, where our magnocellular neurons live. And these are magnocellular. Magno means like big. They have big giant wires. So there's like the cell body of the neuron, magnocellular neuron, and they have these wires that go like way, way, way down to the pituitary gland down here. Right? So that's really strange. And their hormones are made here, and they travel down these wires all the way into little storage vesicles on their ends, and they're stored right here. And once they get the notice to release, they release into the bloodstream. So really weird, magnocellular neurons. Where are they found? You got to memorize these. The sun and the PVN, supraoptic nuclei. These are both hypothalamic, anterior hypothalamic nuclei, and the paraventricular nuclei. Not to be. This is where it gets a little confusing because there's parvocellular neurons. There's magnocellular neurons, and parvocellular neurons can also release ADH. And people get confused between parvocellular and paraventricular nuclei. They're completely different. These are locations. The sun and the PVN are locations. I always think that paraventricular is a very straightforward word. It's like a super optic. They're very descriptive anatomical terms. Parvo, it sounds like a disease. A parvocellular neurons, that doesn't sound like a very descriptive, so I always kind of match that with the neuron type. Neurons, of course, are a little weird anyway. That's, you can figure out your own type of way. But there's many different. There's the hypothalamus. There's many different neurons, right, that live here. Supraoptic is right there. Paraventricular. This is one of the ventricles of the brain. That's paraventricular. I think I have that somewhere that will look better. But let's talk about these magnocellular neurons. So they synthesize not only antidiuretic hormone, but they also synthesize oxytocin, pregnancy hormone. And these hormones are carried all the way down by their axons to the posterior pituitary, where they live in the ends of these axons, waiting to be released when the signal arises. And once they're released, they jump right into the bloodstream. Here's a better drawing. So here's the magnocellular neurons here, and this is the paraventricular nuclei, and there's by the optic chiasma, that's why it's called the supraoptic nuclei. It's right above the optic chiasma, which is right here. And there's where those regions live, and inside of them are these magnocellular neurons. And you can tell they're magna, means long. They have super long axons. They go all the way down to the posterior pituitary, and they hang out. And the created oxytocin and ADH wait for their signal to be released, and they're released right into the bloodstream. Okay, so that's kind of the deal with them. Who else makes it? Does anybody else make ADH, vasopressin? Yeah, parvocellular neurons make it as well. Where are the parvocellular neurons? Well, they're also found in the paraventricular nuclei. So paraventricular nuclei, this guy has parvocellular neurons and magnocellular neurons. The parvocellular neurons have short, stubby, they're not short, they're still really long, but they're not. They don't go all the way down here. So it's kind of a different setup. But you have two kinds of neurons in the paraventricular nuclei. Right? They're found, parvocellular neurons are found in the paraventricular nuclei, so are magnocellular neurons. They're also found in a region called the suprachiasmic nuclei, and they are not formed in the sun, the supraoptic nuclei. Supraoptic nuclei only contains what? Magnocellular neurons. Guarantee questions are coming. Not guarantee, but very high probability questions will be coming about that. Got to know what makes the hormones we study. Parvocellular neurons. The parvocellular neurons, although they make ADH, that's not their main product. Their main product is something called corticotropin releasing hormone, or CRH. And CRH, of course, travels via the vascular system that we'll look at here in a second, but it ends up getting, not by the electrical wires, but by a venous system, it gets dumped into the anterior pituitary, and there's receptors on cells called corticotroph cells. And once CRH binds to anterior pituitary corticotroph cells, a molecule called POMC is released, and that's immediately cleaved by PC1 to form something called adrenocorticotropic hormone, which is a major player. You guys already know about that from classes underneath me have taught you that. So ACTH, but it's important to know ACTH is not really produced directly from corticotroph cells. There's an intermediary. There's a prohormone that's called POMC. We'll look at that when the time comes. So how does it get there? So the axons, as we said, from the parvocellular neurons, they don't go all the way down to the pituitary, as I said. Do I have a picture? Yeah, so here's parvocellular neurons in this little cartoon. And they go down to about here in a region called the median eminence. And that's the end. They dump their hormone product right into a blood system here. And that's called the hypothalamic hypophyseal portal system. Sometimes just called the portal vessels, or portal vessels for short. But the point is, the hormone, CRH is the main hormone, little ADH too under stressful conditions. But little ADH, CRH, it gets into this system, and then via the bloodstream it swims down here. It's carried down, the river flow is toward these. And the corticotroph cells are here. And those are the ones that secrete POMC, which is converted to ACTH. And MSH, that conversion occurs in the skin. We'll talk about that when the time comes. But that's the difference between parvocellular neurons are short. They go through the blood, through a portal system, they go to the anterior pituitary. Magnocellular neurons, which are not drawn. I can draw one here though. Magnocellular neuron has really long axon, goes all the way down here. It doesn't go through the bloodstream at all. So that's the difference between that. That's M for magnocellular. All right, everybody good with that? And so this is the weirdness about ADH. So I'm not sure they understand this completely, but parvocellular neurons do have the ability to secrete ADH as well. And so it's thought to only occur under stressful conditions, although people with mutations who overexpress, maybe they do have a problem like this with the release of ADH inappropriately. But for most people, it tends to occur with high stress from what the research says. And so, they can secrete ADH, and the same pathway gets into the portal system, and it ends up going not ends up going not to the posterior pituitary, but it goes to the anterior pituitary, right? You're probably taught that ADH only goes to the posterior pituitary. It's not true. In some cases, some ADH from parvocellular neurons can end up in the anterior pituitary, and in fact, there are ADH receptors on the corticotroph cells. So it can bind to corticotroph cells and help release POMC, which is converted to ACTH. So that happens usually for our purposes just under stressful, in normal situations under stressful conditions. What stimulates ADH's manufacturing and release? Well, by far the strongest stimuli is hypoosmolarity, aka let's always get these confused. Hyperosmolarity or hyperosmolality. Those are different kind of, remember your general chemistry, different measures of the fluids and things. So what does that mean? Hyperosmolarity. That means hypernatremia for all practical purposes. They're almost AKAs, even though they're technically not. What's hypernatremia mean? Well, the ratio of salt to water is off in your extracellular fluid, so including your blood. So in other words, too much salt, too many molecules of sodium, and not enough molecules of water. So that is a problem. You can think that the extracellular fluid is dehydrated, if you will. All right. So that stimulates the release, hyperosmolarity or hypernatremia. Angiotensin 2, right? So angiotensin 2, there's receptors, angiotensin 2 receptors on parvocellular and magnocellular neurons. And so you can get ADH release from them as well. Right, I think, are we going to stop there? Maybe we should stop, right? It's about, what time is it? Yeah, that's probably enough, I would say. Yep, let's stop it right there, and we'll pick up on Tuesday. We got an hour of this on Tuesday. All right, see you in the next lecture.